Good morning and welcome everyone to the Houston Methodist DeBakey Heart and Vascular Center Grand Rounds. Today we have a true treat, a true privilege. We have Dr. William Stevenson join us from Nashville, from Vanderbilt. Dr. Stevenson is a truly living legend in EP. He is now at Vanderbilt, but he spent most of his career in the Brigham and Women's Hospital in Harvard, in Boston. And then prior to that, he trained at UCLA, where we almost overlap, but not quite. When I started at UCLA, he had been gone for 7 years, and people still talked about him. He is one of the pioneers that taught us how to do VT ablations and how to understand ventricular tachycardia mechanisms, and one of the pioneers in radiofrequency ablation. And he's going to be talking to us about a hot topic in cardiac electrophysiology, which is also important for general clinicians, which is dealing with ventricular extrasystoles, cardiomyopathies, and sudden cardiac death. An issue that many times puzzles the clinician because we go from having irrelevant PVCs that are asymptomatic or maybe cause minor palpitations to PVCs that can actually kill the patients and become a true clinical challenge. So without further ado, Bill, take it.
Thank you very much, Miguel. It's a pleasure to be here with you. Let me attempt to share the right screen. There. Do you hear me and see the screen? Okay.
Yeah.
Okay, great. So here are my disclosures. So let's start with the case.
Bill, you need to go to presenter mode. There's something we're seeing. Maybe swap screens. We see
okay.
you. Yeah.
Let me.
There. Perfect.
Okay. Very good. So 53-year-old woman with palpitations presents to your office. And the story is that she's been aware of some irregular heartbeat that started a few years ago. It's annoying. She hasn't had any rapid palpitations, no syncope, no exertional symptoms. She's got a benign past medical history, no hypertension, no diabetes mellitus. And in the office, you record a 12-lead electrocardiogram, and this is part of the EKG. And you can see here that she's got a couple of sinus beats and then a PVC, followed by another sinus beat, and then a little run of bigeminy. So what does this mean? Well, first, ectopy on a 12-lead EKG in your office is not very common. So if one just looks at a large series of patients with PVCs, it's less than 1% of EKGs will you find spontaneous PVCs. And the people that have PVCs are more likely to have some underlying heart disease than those that don't. They're likely to be a little bit older. They're more likely to be overweight, to have a history of hypertension or diabetes or a past history of some cardiovascular disease. So it should get your attention. And in large population studies, if you just look at people that had PVCs on their 12-lead ECG versus people that did not have PVCs on their 12-lead ECG, you follow those folks for a decade or more, you do find that there are a few more cardiovascular events, heart failure and mortality increases in the people who present with PVCs. So sometimes this is a marker for heart disease, and it can be the initial manifestation of underlying heart disease. So that's an important consideration for us. And it also raises concern of, is the patient at risk for any more serious arrhythmia that might cause syncope or even be a harbinger for sudden death? And of course, what we're hoping, and is often the case, is that these are benign and idiopathic. They may cause the patient some discomfort, but we may be able to manage them simply by reassuring them that there's not any associated underlying heart disease that we can find, and that they're not at increased risk because of their PVCs. So the first thing we focus in on are symptoms. Certainly if the patient's had any symptoms that suggest more concerning arrhythmias that might cause hypotension, so if they've had syncope, near syncope, long runs of palpitations, that should get our attention. Another very important theme of today's talk is going to be genetics, and the family history is important. Do they have a family history of sudden death, of cardiomyopathy? Anybody in the family with an implanted defibrillator? Those factors should get your attention. And then, of course, we'll examine the patient and focus on any cardiac abnormality. And then on the EKG, we're going to be interested in whether there's any additional sign of underlying heart disease and where are these PVCs coming from, because that's actually useful in terms of informing us about the possible etiology of the ectopy and what any underlying heart disease might be. And we're likely going to want some cardiac imaging to reassure us about cardiac function, that this isn't an initial presentation of a myopathic process, something that we wouldn't pick up from these other tests. So here is her 12-lead electrocardiogram. And you can see that she's having the PVCs, that if we scrutinize the QRS complexes, ST segments, and T waves, they're really normal. The conducted beats are normal, and that's reassuring. And then the location of the PVCs, where are these PVCs originating from? And I have a very simple approach to trying to figure that out. So the first thing we do is look at V1. And you think about the position of V1 on the anterior chest wall, and immediately underneath that is the first part of the heart that you get to is the right atrium and right ventricle. So if you have a dominant S wave in V1, a so-called left bundle branch block-like pattern in V1, that tells you have a vector that's moving away from the anterior chest wall, and that is produced by initial depolarization of either the right ventricle or the interventricular septum. If you have a dominant R wave in V1, that tells you that initial depolarization is originating in the posterior ventricle, the left ventricle, giving you a vector coming at V1. And then we look at the frontal plane axis. And if you initially depolarize the diaphragmatic surface of the heart, you expect to get a vector which is moving superiorly, so big S waves in 2, 3, and AVF, in the inferior leads. And if you initially depolarize the anterior aspect of the ventricle, or the cranial aspect, you get dominant R waves in the inferior leads. And then to get our position in the base to apex sort of plane, we look at those leads which are positioned out over the left ventricular apex, V4 and V3. And if you initially depolarize the apex of the heart, you expect a vector that's moving away from those leads, so you get big S waves in V3 and V4. In contrast, if you depolarize a site starting at the base of the heart, you have large R waves in V3 and V4. So those 3 steps get you pretty far along into sorting out where the PVCs are coming from. So in this case, the PVCs have a left bundle branch block configuration. So we're thinking right ventricle or interventricular septum, and great big R waves in 2, 3, and AVF, so up towards the cranial aspect of the heart. And the most cranial aspect of the heart in the right ventricle is the right ventricular outflow tract. And this is the most common location for idiopathic PVCs. So when we see this PVC morphology, we're thinking, is there right ventricular disease, or is this just idiopathic PVCs without underlying significant heart disease? So then we got cardiac imaging. In her case, she had an echocardiogram. It was actually done before she was sent to us, and this is an excerpt from the report. And her left ventricular ejection fraction is estimated to be 45 to 50%, so a little bit depressed. So what does this mean? This is a little bit concerning in someone presenting with a ventricular arrhythmia. And there are three possibilities that you wish to consider. The first is that, well, maybe these PVCs are secondary to a cardiomyopathic process. And if that's the case, if we suppress the ectopy, what we would expect is that left ventricular function will remain abnormal. A second possibility is that the PVCs are causing the ventricular dysfunction. And if we suppress them, we'll see a gradual improvement in ventricular dysfunction. And then a third possibility is that her ventricular function is really normal, but she's having so many PVCs at the time of the echocardiogram that we can't reliably assess her left ventricular function. So one of those three possibilities is likely what's going on. So, and one can appreciate how PVCs can certainly have an important hemodynamic effect in some patients. So this is a tracing from the cath lab in a patient who's in ventricular bigeminy, and you can see that the PVCs don't generate much of a systolic pressure. So functionally, this patient has quite a bradycardia related to bigeminy, and you can imagine that that could be symptomatic, and that prolonged periods of that sort of bradycardic, effectively bradycardic rate could be significantly an issue. Well, we know that people that have a lot of PVCs can develop depressed ventricular function. And one of the best studies to give us an idea of how frequently we should be worried about that was published several years ago from a French group, 239 patients who had normal ventricular function and right ventricular outflow tract PVCs, who were then followed for a minimum of 4 years. And 5% of those folks developed a decrease in their left ventricular ejection fraction of greater than 6%. And by and large, it was the people who had very frequent PVCs. So on the graph to the right here, you see the PVC prevalence plotted on the x-axis, and the change in ejection fraction plotted on the y-axis. So these folks down here in the lower right-hand corner had a fall in their ejection fraction. By and large, they pretty much had more than 20,000 PVCs in 24 hours. Now you have about 100,000 heartbeats per day. So that's about 20% PVC frequency. And those who had less than that, it was quite uncommon to have any decrease in ventricular function. And none of the patients in this cohort developed symptomatic heart disease, and there were no sudden deaths and no sustained ventricular tachycardia. This is similar data from the University of Michigan of people who were referred for ablation of their PVCs. Those who had depressed ventricular function, so down in this, in the left side of the graph here, most of them had more than 24% of their daily beats on a 24-hour Holter were PVCs. So that seems to be sort of the cutoff. If you've got more than 20% of PVCs, we get worried. And we know that if you suppress those PVCs, as was done by ablation in this University of Michigan series, that very often you saw an improvement in left ventricular function, as is shown here. So how many PVCs does our patient have? Well, a 10-second ECG, so that's about 1/8,640th of a day. If you multiplied those 6 PVCs in her 10-second ECG strip, you'd think, well, she could be having a ton of PVCs, even 60%. But the 24-hour Holter shows that at night they were pretty quiescent, And in fact, she has a PVC burden of about 20%. So enough that her mild left ventricular dysfunction could be related to her PVCs. She had one little triplet, not unusual in people with idiopathic PVCs. So from the guidelines for people who have PVCs that require suppression either for symptoms or because of concern of declining left ventricular function, which the guidelines note generally means they've got more than 15% of their beats are PVCs, and for whom antiarrhythmic medications are not effective, not tolerated, or not the patient's preference, catheter ablation is quite reasonable. And that's the discussion we usually have with the patient. Do they want to try a medication? We usually would start with a beta blocker. We might consider a calcium channel blocker if that's ineffective. And then if those are not ineffective, or the patient doesn't tolerate those well, or doesn't wish to pursue that, then we're usually talking about catheter ablation. Because in the setting of depressed ventricular function, we worry a little bit about giving them other antiarrhythmic drugs other than amiodarone, although there is some anecdotal experience with flecainide in this situation. And it's probably safe to do that as long as left ventricular function improves. In her case, she was symptomatic with her beats. She didn't want to take a medication. And so we proceeded to an EP study. And what we found was a focal origin PVC in the right ventricular outflow tract. And this is the type of mapping data that we now acquire routinely at EP studies. What you're looking at here is the right ventricle as viewed from a posterior projection on the left. So you see the tricuspid valve annulus, the pulmonary valve annulus. The colors here reflect the activation time. So red is early, and then it moves through the colors of the rainbow, and it creates these beautiful images that Dr. Valderrabano and I are used to looking at every day in the EP lab. You can see that this is a focus that originates in this area. So interestingly, in her case, we ablated right there and the PVCs didn't go away. And what was going on is that these PVCs originate in a sleeve of muscle that extends up above the pulmonic valve. And when I play this image, if you look at the intracardiac ultrasound image over to the right here, what you're seeing is the ablation catheter is up in the pulmonary artery and curved back around in a loop. And the tip of it is sitting right here, just on the other side of the pulmonic valve leaflet, which you see here. You can see what close proximity we're in to the aorta as well. And there are sleeves of muscle that commonly extend up between the aorta and the pulmonary artery that can be a source for these arrhythmias. And ablation, in her case, required finding that little spot just on the other side of the pulmonary valve, and then that abolished her ventricular arrhythmia. So there was RF on, and the PVCs are gone. This is a catheter-induced PVC from somewhere else. So in summary, frequent PVCs can depress left ventricular function and cause a form of tachycardia-induced cardiomyopathy. Usually it requires more than 20,000 PVCs for 24 hours, but there's a fair amount of variability day to day in patients' frequency of PVCs. So we do see patients who on any given 24-hour period have fewer PVCs than that, but still have concern about depressed ventricular function. The duration and the frequency of arrhythmia required to cause this dysfunction is not clear and is the subject of some ongoing investigations. Once you get rid of the PVCs, the ventricular dysfunction usually improves over weeks to months after the ablation. If it's immediately normal, then probably the PVCs were having more of an effect on diminishing your capability to accurately measure ventricular function as opposed to depressing it. And differentiation from cardiomyopathy causing PVCs can be difficult. So very often the way we sort this out is by simply suppressing the PVCs and then reassessing ventricular function. So let me then show you another case. So this is a 77-year-old man, and he has a history of, he's had these frequent PVCs noted by his physician initially for over 20 years. And he's aware that they're there, but he's learned to live with them. They don't bother him. He's very active. He logs over 10,000 steps daily. And he had an episode of syncope while working at home. And here is his 12-lead EKG. And you can see that he is also having PVCs. So if we apply our algorithm, V1 in this case is a dominant R wave. So over in the left ventricle, the inferior leads, 2, 3, and ADF, have tall R waves. So it's up towards the top of the heart. So this arrhythmia likely originates from the left ventricular outflow tract rather than the right ventricular outflow tract. Now, that's also a common location for idiopathic arrhythmias. In his case, the rest of his EKG is really pretty benign. Perhaps he's got some non-specific repolarization changes in the inferior leads, but not much else that looks particularly worrisome. And you see in the schematic here at the bottom, this is the cardiac anatomy that, again, is very important for understanding these outflow arrhythmias. The aortic valve is right in the center of the heart and posterior to the pulmonic valve. So if you consider where V1 is on the chest wall, as you depolarize the heart from the right ventricle, you've got that dominant S wave like we talked about. As you move progressively more posteriorly and towards the left, depolarization from foci in that location produce an initial R wave in V1. And the more posterior you get, the larger that R wave becomes. So in his case, this is from the left ventricular outflow tract. Well, actually, what happened with this guy is when the EMTs arrived after he'd had the syncopal episode, they found him in this tachycardia. And you can see this is a left bundle branch block-like tachycardia with an inferior axis. So this looks a little bit more like a right ventricular outflow tract, wide complex ventricular tachycardia. So the rest of his history is pretty benign. Other than those PVCs, he had not previously recognized any cardiac symptoms. His family history is benign, no sudden death, no heart failure. His echocardiogram showed depressed ventricular function with an ejection fraction of 35 to 45% with mild MR and some left atrial enlargement. So it was very important to rule out coronary disease. He had coronary angiography and he had mild non-obstructive disease. So we took him to the EP lab. And in contrast to Our Lady with the PVCs, this fellow has inducible sustained ventricular tachycardia. And he actually has more than one morphology of sustained VT. So you can see VT1 here on the left, and you can probably appreciate that at least in lead 3 here, VT1 is pretty different than a subsequently induced VT2. So he has multiple morphologies of ventricular tachycardia. And that is extremely rare in patients who do not have structural heart disease. This almost always indicates that there is the presence of some scar in the heart that is the substrate for a reentrant ventricular tachycardia. So he likely has scar-related reentry. And some other findings from his EP study, up at the upper right, you see a map of his left ventricle, and this is a voltage map, so that the colors reflect the amplitude of the electrical signal that's recorded at different spots throughout the heart. Purple is normal, and red and green and yellow are low amplitude, and this indicates that he's got a low amplitude area, which is what one sees in scars, areas where the myocardium has been replaced by fibrosis. And so he's got scar involving the basal septum and up around the aortic valve. And we recorded abnormal electrograms consistent with scar from that region. So low voltage scar, complex electrograms. We ablated his PVCs and his VT, and he had no VT inducible after ablation. But he's got underlying structural heart disease with fibrosis. So this is a non-ischemic dilated cardiomyopathy. characterized by reduced ventricular function, ventricular dilatation that's not related to coronary artery disease. And you've, of course, seen many, many people who carry this diagnosis. It's also referred to as dilated cardiomyopathy. Very often patients are told that, well, it's probably due to a virus, so post-viral cardiomyopathy, which often is not the case in many of these, or idiopathic dilated cardiomyopathy. We don't know the cause. But it's important to recognize that one of the areas that's really advanced pretty dramatically here in the past decade is our realization that we often can find a cause for non-ischemic dilated cardiomyopathy. About a third of cases have a genetic etiology. And there are some phenotypes that are particularly arrhythmogenic. So this is a very important consideration. Another important cause are inflammatory diseases. And of inflammatory cardiomyopathies that cause ventricular arrhythmias, a really important one is cardiac involvement with sarcoidosis. So genetics, sarcoid, autoimmune diseases are high on our list. And then, of course, other causes, toxins. These are anthracyclines from chemotherapy, other chemotherapeutic agents, alcohol. These are less frequently, in our experience, associated with ventricular arrhythmias. And then, of course, among the reversible causes of cardiomyopathy, we just talked about frequent PVCs, but also incessant tachycardia, such as rapid atrial fibrillation, can produce depressed ventricular function. So arrhythmias are an important possible presentation of non-ischemic cardiomyopathy. It may be PVCs, might be atrial fibrillation, in some diseases, conduction abnormalities, less commonly monomorphic and polymorphic VTs or cardiac arrest and syncope. So initial evaluation of the patient with non-ischemic cardiomyopathy to characterize the severity of the ventricular dysfunction, define the etiology, rule out or in coronary disease, valvular heart disease, address any potential aggravating factors such as rapid atrial fibrillation, very frequent PVCs, conduction abnormalities, left bundle branch block, which may impair ventricular function, optimize medical therapy, and then assess the patient's arrhythmia risk and their risk for sudden death. Do they warrant any protection? Do they warrant a defibrillator for that? Now, sustained monomorphic VT in non-ischemic cardiomyopathy is not very common. And the vast majority of them are due to scars, as we saw in our patient, and reentry in areas of scar that form in the myocardium. And this scarring or fibrosis anywhere in the heart can give rise to reentrant VTs. But in non-ischemic cardiomyopathies, the scars tend to develop in specific areas. And very often they're along a valve annulus. And the EKG morphology of the VT, when you can capture that, or of their PVCs, often suggests to you what's going on and where the scar is located. So these are a couple of images from a very nice study from the group at Leiden in the Netherlands. These are MR images, and the brown areas are regions of fibrosis that have been reconstructed from the MR images. And then you see the associated EKGs of the patient's VTs there to the right of the image. So here's fibrosis along that periaortic area, as in our patients, and down the interventricular septum. You would expect that a VT originating from that septal area would give you a left bundle branch block configuration and an inferiorly directed frontal plane axis when the VT comes from up near the aortic valve. And this is, of course, what we saw recorded in our patient. You can also get right bundle branch block configuration VTs with an inferior axis if the VT originates more from the lateral part of this sort of periaortic scar. And this is a very common scar pattern for patients with non-ischemic cardiomyopathies who have monomorphic VTs. A second common pattern involves, again, the base of the heart along the mitral annulus, but the lateral wall. And patients that develop VT from these scars typically have right bundle branch block, right axis VTs. And very often these scars reach out to the epicardial surface. And that's relevant to electrophysiologists who try to ablate these things, because often you need to go into the pericardium and attack these circuits from the epicardial surface of the heart. Now, it's interesting, why do patients with non-ischemic cardiomyopathy develop fibrosis? And we don't really know. But if you do MR imaging of patients with non-ischemic dilated cardiomyopathy of unclear etiology, about a third of them will have substantial areas of fibrosis, which is likely replacement fibrosis. Very often they'll have diffuse mid-wall sorts of patterns of fibrosis. And these are not particularly associated with monomorphic VT. They can be, but not as frequently as when you've got scar back along the base of the heart. And the patients, those third of patients who have prominent myocardial fibrosis, are at increased risk for sudden death during follow-up. And that's been shown in several sizable MR studies. This was one of the early ones for patients who had significant mid-wall fibrosis, death rate during follow-up of 26%, most of which were sudden, substantially lower death risk for patients without substantial fibrosis. Now, as I mentioned, sustained monomorphic VT is not that common in patients with non-ischemic cardiomyopathy. And some years ago, there was a trial in which patients who had depressed ventricular function due to non-ischemic dilated cardiomyopathy and non-sustained ventricular tachycardia were randomized to defibrillator, no defibrillator. And one of the things that was observed is that during follow-up, the arrhythmia risk was only about 6% per year. And about half of those arrhythmias, sustained arrhythmias, were monomorphic VT, and the other half were polymorphic VT and ventricular fibrillation. So monomorphic VT is not very common in non-ischemic cardiomyopathy. Polymorphic VT, or VF, occurs with a similar frequency. The mechanisms for that are not so well defined as they are for monomorphic VT. But there are a lot of electrophysiologic abnormalizes that accompany dilated heart failure and ventricular hypertrophy, and those include abnormalities in repolarizing currents, abnormalities in calcium handling, and then interstitial fibrosis, which also occurs and reduces cellular coupling. And all of these things would be expected to make the ventricle more susceptible to ventricular fibrillation. So it's interesting that the risk of sudden death in patients with non-ischemic dilated cardiomyopathy has really been diminishing over the past couple of decades as a consequence, I think, of advances in medical therapy. And so this is the Danish trial. This was a trial in which patients with non-ischemic dilated cardiomyopathy who had symptomatic heart failure and ejection fractions of 35% or less were randomized to defibrillator, no defibrillator. And surprisingly, there was not a mortality benefit for the placement of a defibrillator. And that was due to the quite low incidence, around 1% per year, of sudden death events in the non-ischemic dilated cardiomyopathy population. And sudden death was reduced in the trial, but this wasn't sufficient to translate to a reduction in overall mortality. And again, I think that relates to just the fact that medical therapy really is improving the outcomes and reducing the risk of sudden death in patients with heart failure. And this is from this nice paper in the New England Journal a few years ago that just makes the point that from 1998 to 2014, we've had a lot of advances in therapy. And if you look at the survival curves for those trials over that period of time, they show a nice consistent reduction in the risk of sudden death This is that information plotted another way from 1995 on your left to 2011 on the right, and you can see the decrease in both the control and the treatment groups for these randomized trials in heart failure. And this is sudden death on the abscissa. So mineralocorticoid antagonists, beta blockers, ACE inhibitors, and angiotensin receptor blockers, and then neprilysin ARB antagonists have all been associated with improvements in sudden death, and this is, of course, the most recent example of that. However, if you put everything together, you can still show that there is a benefit in mortality for implanting defibrillators in patients who are at increased risk. It's just the benefit is relatively modest, and it takes often years before it's manifest. And it's very common for us to see a patient who had a defibrillator implanted for primary prevention, who it's not until their second defibrillator, their second pulse generator change for battery depletion, that they start getting into trouble with arrhythmias. So this is still the current guidelines in patients with non-ischemic cardiomyopathy and heart failure, symptoms and ejection fraction of 35% or less despite guideline-directed therapy, and ICD is recommended if meaningful survival of greater than 1 year is anticipated. And even for those with New York Heart Association Class 1 symptoms who have an ejection fraction of less than 35%, it's a 2B indication to give those folks a defibrillator. Now, one of the caveats with this is for the patient with newly diagnosed heart failure, or newly diagnosed ventricular dysfunction. The guidelines specify that we should wait 3 months and reassess ventricular function after they've had guideline-directed medical therapy for that period of time. So one of the things that comes up is who's going to improve, and there are some groups that we can feel pretty confident have a good chance of improving. So the patient who has atrial fibrillation that's relatively recently recognized that we're going to be able to treat, the patient who has frequent PVCs, as we've been talking about. And then another consideration are those who have a wide QRS, who have a left bundle branch block. And this is data from a Duke registry looking at patients who presented with left ventricular ejection fraction of less than 35%, and then were followed over time to see who improved to an ejection fraction better than 35%. And those who improved were more likely to have a narrow QRS. Those who had a wide left bundle were less likely to improve. Only 23% of them had an improvement in ventricular function. So conduction disease is often probably associated with some degree of fibrosis. And this is a relevant group because we know that if we offer them biventricular pacing and resynchronize their hearts, we have a better chance of improving their ventricular function. Atrial fibrillation is another important consideration, and I'll show you a little bit of data. There are a lot of studies that make this point, but this is the camera trial, and patients who had atrial fibrillation, depressed ventricular function, were randomized to catheter ablation versus medical rate control. And their at baseline, their heart rates were 79 in the ablation-treated group in AFib, 85, so within the range of what we would consider reasonable rate control at rest for patients with atrial fibrillation. In the catheter ablation group, ablation reduced their AFib burden quite substantially, and left ventricular ejection fraction overall for the group improved quite substantially. In the rate control group, their heart rates on therapy were about 80 beats per minute. So again, what we would generally consider acceptable rate control, the ejection fraction improved a little bit, 34 to 39% overall for the group, but relatively modestly. And there is this appreciation that, yes, a rapid rate, we know that can definitely depress ventricular function. But there's a surprising amount of evidence that supports that even perhaps the irregularity of the R-to-R intervals during atrial fibrillation may be sufficiently hemodynamically adverse that can also contribute to depressed ventricular function, similar to having PVCs in some patients. And we don't really know how to identify those patients at this point. However, fibrosis probably also is a useful indicator. So in a sub-study from this trial, they had MR imaging and looked at the patients who had detectable fibrosis, late gadolinium enhancement on their MR images in the ventricle versus those that did not. And patients without late gadolinium enhancement present in the ventricle were more likely to show or showed a larger improvement in ventricular function than those that had areas of fibrosis in the ventricle. So consideration for treating atrial fibrillation, consideration of if they have left bundle branch block are relevant for managing these folks even when they present early. Now, we've already mentioned that SCAR is associated with arrhythmia risk as well. And this is just summary data, again, from the University of Michigan, that of patients who are referred for catheter ablation of PVCs, that sustained VT was inducible in 5% of those folks, and all of them had evidence of SCAR on their MR imaging. So some of the people who have PVCs, where we're thinking, well, maybe we get rid of the PVCs, their ventricular function will improve, some of them already have enough SCAR that puts them at risk due to sustained ventricular tachycardia. And programmed ventricular stimulation then is sometimes a useful consideration in these patients when you're worried about them. Somebody who's got fibrosis in their ventricle, but who may not quite meet criteria for implantation of a defibrillator, if they are found to have inducible VT, their risk of spontaneous VT during follow-up is increased. So now back to our guy. What's the etiology of this cardiomyopathy, right? So genetic, well, he's got no family history and he's presenting at the age of 77. Inflammatory, a bit old for sarcoid, but still could be, and this would be something that would be important to find. We don't have any history of toxin exposure. Maybe his PVCs were frequent enough to contribute, but it's unusual for PVC-induced cardiomyopathy to produce SCAR. Usually the SCAR is a part of a cardiomyopathic process. Well, we did an endomyocardial biopsy, and that was unremarkable, and we sent genetics, and lo and behold, he's got a pathogenic Titin mutation. So this is a genetic cardiomyopathy, 20-year history of PVCs, finally developing clinical manifestations in his 70s, no family history. And we now recognize that there are many genetic cardiomyopathies that are particularly arrhythmogenic. Now, some of those involve desmosomal proteins, which we've long recognized can cause arrhythmogenic right ventricular cardiomyopathy, which is a very arrhythmogenic cardiomyopathy. So plakoglobin, plakophilin, those we know are very arrhythmogenic and occasionally will cause a predominant left ventricular phenotype. But there are a number of others as well, and these usually are associated with areas of SCAR and ventricular tachycardia. And perhaps one of the worst ones is lamin AC. Lamin is a nuclear envelope protein. And in patients who have non-ischemic cardiomyopathies, if they're found to have a genetic cause of their mutation, of their cardiomyopathy, they have a worse outcome overall, a higher mortality than patients who do not have a genetic cause identified with genetic testing. And that is in part driven by the very severe prognosis of patients with lamin heart disease. And this is from a series of patients with Lamin cardiomyopathy that by the time they present with ventricular arrhythmias, the likelihood of survival without transplant for 7 years is very, very low. And you can see that from the time of initial presentation, initial clinical contact, to over the next 20 years or so, by 15 to 20 years, 80% of people are dealing with atrial arrhythmias or ventricular arrhythmias, conduction disease. So this is really a very bad form of cardiomyopathy, and most of these folks will wind up needing cardiac transplantation. So back to the guidelines, these high-risk genetic forms, particularly Lamin, is recognized as called out in the guidelines. And the patient who has non-ischemic cardiomyopathy due to Lamin disease, who's got depressed ventricular function, EF less than 45%, non-sustained VT, men seem to have worse prognosis than women. Some mutations are worse than others, nonsense mutations. An ICD received a 2A indication in that group. And of course, cascade screening for family members is important in these diseases when you find one of these, because sometimes the initial presentation of the disease is sudden death. So screening family members is important. And as we mentioned with Lamin disease, because the prognosis is so poor, it's worthwhile recognizing that up front, getting the patient plugged in with your advanced heart failure colleagues. Unfortunately, we don't have specific therapies for genetic diseases at this time, but hopefully those are coming, as we've seen emerge in cystic fibrosis and some other genetic diseases. Okay, let's do another case. So this is a middle-aged man who showed up in our emergency room with palpitations, and this was his EKG. So you look at this, and from what we've discussed before, you see left bundle branch block. So we're thinking septum or right ventricular outflow tract, big R waves, 2, 3, and AVF. So maybe this is idiopathic right ventricular outflow tract VT. But when this was cardioverted, this was the underlying sinus rhythm EKG. And you can see that he's got first-degree AV block with quite a long PR interval and right bundle branch block, so prominent conduction disease. And this was sarcoidosis. So sarcoidosis is the granulomatous disease that can affect any organ in the body. About 5% of cases of sarcoid involve only the heart. And when that's the case, it's really hard to diagnose it, because the involvement is patchy, so biopsies will often miss it. If you get it on a biopsy, then you've got the diagnosis, but sadly, it doesn't happen as often as we would like. If there's any evidence of extracardiac sarcoid, biopsy of those tissues or lymph nodes is often more helpful. And sarcoid can cause heart block, ventricular tachycardia, and atrial arrhythmias. And sarcoid can involve predominantly the right ventricle and largely spare the left ventricle. And that was the case in this heart. This is a voltage map of the right ventricle, and the whole anterior portion of the RV is scar. This is the heart explanted at the time of transplant. And you can see the extensively scarred right ventricle with relative sparing of the left ventricle. So this can mimic arrhythmogenic right ventricular cardiomyopathy. One of the tests which is useful in sarcoid is a FDG PET done after the patient abstains from having any carbohydrate for 24 to 48 hours. So the heart switches over to fatty acid metabolism, and then any glucose uptake that you see in the myocardium is likely reflective of the presence of inflammatory cells, white cells. This is then very suggestive of the presence of sarcoid, and is useful, we think, helpful for monitoring therapy for sarcoid. And the extent of involvement of the heart and right ventricular involvement on FDG PET is associated with worse outcomes in patients who have sarcoid. So non-ischemic dilated cardiomyopathies with ventricular scar, the scar location can suggest the disease etiology as well. And we've talked about those prominent scars along the mitral annulus and in the periaortic region. In sarcoid, the scar can be anywhere and can involve the right ventricle. So right ventricular scar really makes you concerned about this. In post-viral myocarditis, scar is more typically subepicardial and basolateral. And there are a number of studies that are emerging now that are trying to make these correlations between scar location and phenotype of the heart disease. And often we have a good indication of where the scar is from the patient's arrhythmias, as we've reviewed from the EKG. So I'll summarize that ventricular arrhythmias are a common presentation for non-ischemic cardiomyopathies. Ventricular scars are an important arrhythmia substrate, and the location varies with the type of heart disease and can be inferred from the QRS morphology of the arrhythmia. Cardiomyopathies that are labeled idiopathic often are not idiopathic, and increasingly more investigation will reveal that about a third of them are genetic, and this can be important to recognize. Some are arrhythmia-induced, and it's very important to have a high index of suspicion for inflammatory cardiomyopathies because these can potentially be treated. Thank you very much.
Great. Is my mic on? All right. So, excellent as usual, how to make a very complex issue seem simple. And I have three questions for you. The one is, we've gone, at least I have gone through a whole range of diagnostic tests that I do for someone that comes with PVC. So if they look like RVUT, many years ago I wouldn't do anything, maybe an echo and then ablate them. And now I see myself that I get an MRI on everybody, and sometimes even PET scans, and now genetic testing. And in the case that you showed, what I was surprised is when you see scar, I typically don't think of a genetic cause except for ARVC, right? The ARVC obviously leads to scar, but in general, I do genetic testing when I'm looking for idiopathic, like maybe some ion channel mutations or other things. But the case you showed shows the value of a genetic testing in a patient that had a septal scar. So how do you kind of prioritize diagnostic testing in PVCs?
Yeah, it really has evolved. Same as you. 20 years ago, we'd see a patient with outflow tract PVCs, and if they weren't bothering them, we would often say, "Don't worry, come back if it's bothering you more." And now we know that some of those people will develop a decrease in ventricular function, so we can't ignore them. We have to at least look at the frequency of the PVCs and consider that, and consider that some of these will be the initial presentation of a myopathic process that might not emerge for a long period of time. So I think pretty much what you are now doing. So if somebody has PVCs and they look like they're from the right ventricular outflow tract, EKG is totally normal, no family history. I will always get some imaging, either an echo, or if I'm a little more worried than an echo, then I definitely get an MRI. And then if no therapy is required, I do see those patients back once a year for the next couple of years, just because of that concern. My thought is that some of those, one other thing we should mention is that some of these people with idiopathic PVCs, the PVCs will diminish and almost resolve with time. There are a few series of that. So I always hold that out to the patient as this may go away, it may get better, otherwise it'll wax and wane. If there's anything at all concerning, sinus rhythm EKG is not completely normal, a family history of any concern. Very often the sudden death family history is, oh, my uncle died of a massive heart attack. And the massive heart attack was in fact that he died in his sleep at night, and the family was told he had a massive heart attack even though no autopsy was done. It's very common that if you just dig a little bit deeper, you find that some of these people who die of massive heart attacks, and you're thinking, oh, they had coronary disease. In fact, it wasn't necessarily that, and you really don't know. So anything like that, I'm more inclined to get an MRI. And if we see any scar, then we follow that up and we worry, is this the initial presentation of sarcoid? We think about getting a PET. If there's anything more than minimal scar at, say, the right ventricular insertion into the septum, where sometimes there'll be a little bit of delayed gadolinium enhancement, we do think about, should we really go to the EP lab and both fix the PVCs, but also do program stim and confirm that, yes, there's nothing inducible at this point in time, and then define our program to follow up from there.
And what's been your experience with biopsying these cases when you see something, particularly if you see something hot on the PET scan and it matches the scar on MRI? We've had kind of, every now and then we get a case that we get very excited. We make a diagnosis of sarcoid or amyloid in one case, but a lot of non-specific findings that get you frustrated.
Yeah, that is our experience too. We would very much like to be able to guide the biopsy to an area that we think is in the border of a region of affected myocardium. We learned early on that if we did a voltage map, and then we went to the area of low voltage, those biopsies were always just fibrous tissue and nothing else, because there's got to be a lot of fibrosis to produce a low voltage area.
Yeah.
So that people have shown that you need to go to kind of a border area. But our experience has been, we're not really that skilled enough to be able to maneuver the biotome to border areas in many patients. So we haven't had very good, I would say that our diagnostic yield on biopsies is below 20%, certainly.
Yeah, that's
if we see some enlarged lymph nodes that can be done with a transbronchial biopsy or so, we're more likely to do that first.
Yeah.
And but we still do cardiac biopsies at the time of the EP study, or sometimes at the time of defibrillator implantation. Yeah. But the yield has been disappointingly low.
Yeah. So I have a question from the audience. Thanks for your excellent presentation, Dr. Stevenson. Besides PVC burden, what should cardiologists consider before referring for PVC ablation? Do you see CMR risk scores like ABC-VT or genetic screenings as emerging risk indicator tools to guide management?
Yeah, those are relevant considerations. So certainly symptoms. If the patient is having a lot of symptoms, well, you're probably going to want to deal with those PVCs anyway. And at the time of the EP study, you can also do program stimulation, as we've mentioned. But if there's any evidence of abnormality, doing some additional testing with MR imaging, taking a careful family history is quite relevant. And even if you find a genetic cardiomyopathy, but the patient has lots of PVCs, it's still possible those PVCs are contributing to the ventricular dysfunction. So one of the other thing that we didn't talk about is that multifocal PVCs, so somebody that has PVCs coming from multiple areas, that's more likely to be associated with structural disease, and the ablation outcomes for that are going to be not as good. Yeah. Because if somebody has PVCs from one or two spots, Dr. Valderrabano can probably help you with that. If they're from 10 spots, that's kind of asking a lot.
Yeah. So one last quick thing, PVCs and sudden death. So we had a patient not long ago, passed out, was found by his dad gasping, agonal breathing, and by some miracle he came back. And then we showed up in the ER, he's in bigeminy, and the PVCs appear from the RV apex. Everything is normal otherwise. And of course, they give him amiodarone and the PVCs go away. MRI is normal. What do you do? So I tell you what I did. We made a EP study positive, and I know pushing the limit, put a subcutaneous ICD, and 6 months later had VF, had run of bigeminy and documented VF. So we found the PVCs off amiodarone and ablated in the apex. It was not an easy ablation, very unstable catheter manipulation. The idea was we were looking for Purkinje-associated PVCs. Couldn't really find any typical marker, but anyway, I ablated it. What is your approach in situations like this when you suspect a PVC could be causing sudden death, but you have no definitive proof? And it's not like you're gambling with a minor issue. It's like, yeah, this could kill you, maybe it wouldn't kill you. We don't know, right? So it's a tough.
Yeah. So there are these idiopathic, what's been called idiopathic ventricular fibrillation.
Yeah.
And they fall into a couple of different groups, but one of them are people that have PVCs that usually originate from the Purkinje system somewhere, and that very often have very short coupling intervals. So the PVC interrupts the T wave, and that is sometimes can initiate ventricular fibrillation. And ablation targeting those PVCs has been used mostly in people who have had a lot of ventricular fibrillation. So we know that there are some people that do this, that if we ablate their PVCs, we can get control of their ventricular fibrillation. But during long-term follow-up, there's a recurrence rate that in the Bordeaux series was around 15%. So it's not that you can tell them it's never going to happen again. So I think that if you've identified somebody who's had a possible VF episode or a severe syncopal episode, or they came back with resuscitation and you don't know what the rhythm was, and now they've got these PVCs, I'm uncomfortable saying, oh, well, the PVCs are gone now, this won't happen again. I agree with you. I think they need a safety net. And those idiopathic VFs, that's a very interesting area all by itself, as you know, as you know well, that those are not often so idiopathic anymore either.
Yeah, and you get the feeling you can ablate them, but if there's something diseased in the Purkinje system, it could probably pop up somewhere else. I mean, there's millions of Purkinje muscle junctions everywhere, right? So it's why one spot and then feel safe about that.
Yes.
It's anyway. Yes. This was great, Bill. Thank you for joining us. I wish we could continue talking, but we gotta go on with our days. Thank you very much.
Pleasure. Thank you so much.
Bye-bye. Okay, so we're done.